Hello everyone, my name is Akanksha Mela and today I will be presenting a case of acute Pylephlebitis, a rare and fatal complication of sigmoid diverticulitis. Now, as you all know, diverticulitis is caused by inflammation of outpouchings within the colon wall, most commonly occurring in the sigmoid colon, and these can often cause intra-abdominal abscesses, fistulas, as well as perforations. A rare complication caused by extensive inflammation of the area is mesenteric venous thrombosis, also known as Pylephlebitis, the delayed diagnosis of which can be fatal. And so today I want to present to you a case of a 59-year-old male with a known history of diverticulosis who presented to our emergency department complaining of 4 days of fevers as well as generalized abdominal pain. On admission, he was febrile with a temperature of 101 degrees Fahrenheit as well as a heart rate anywhere between 110 to 120. A CT of the abdomen on admission did show inflammation adjacent to the sigmoid colon with mesenteric venous gas suggestive of sigmoid diverticulitis. And so with that presumptive diagnosis in mind, the patient was started on IV fluids as well as antimicrobial therapy with ceftriaxone and metronidazole. The next day, however, a rapid response was called due to rigors. He was found to be tachycardic, tachypneic, EKG showing new onset atrial fibrillation, and labs drawn at that time showed a lactate of 4 and a white blood cell count of 15.7. Now, his hospital course really continued to be complicated by these episodes of recurrent rigors, necessitating transfer to the ICU as well as mechanical ventilation. His blood cultures grew E. coli, Enterococcus faecalis, as well as Candida gillibarda, and antimicrobial therapy with ampicillin, ceftriaxone, metronidazole, and fluconazole was initiated. A repeat abdominal CT on hospital day 11 did show gas in the inferior mesenteric vein, and when a CT abdomen was repeated on hospital day 11, it showed extensive portal venous gas, a thrombus in the main portal vein, as well as focal areas of infarct in both the left as well as the right hepatic lobe, at which point the patient was started on IV unfractioned heparin. He also underwent an exploratory laparotomy with a sigmoid colon resection as well as a descending colostomy, following which anticoagulation was switched to apixaban 5 milligrams twice daily. The patient was eventually discharged home on apixaban as well as a 6-week antibiotic therapy course of vancomycin, ertapenem, as well as fluconazole. A repeat CT scan at 3 months showed interval improvement of the portal vein thrombosis, following which he underwent colostomy reversal, and a CAT scan at 6 months showed near to complete resolution of the thrombosis as well. And so symptoms of Pylephlebitis can be largely nonspecific, making the diagnosis largely elusive. This can lead to delayed recognition as well as a more complicated clinical course as described in this case. And so it's really important to have a high degree of suspicion when making the diagnosis. In regards to the standard of care, it currently includes targeting the underlying infection through surgery as well as antibiotics. The role of anticoagulation, however, remains unclear in the absence of larger randomized controlled trials. As described in our case, anticoagulation can prove to be beneficial in achieving resolution of the portal vein thrombosis. The literature currently consists of retrospective observational studies, which have shown that anticoagulation significantly improves the rate of resolution as well as reduces the rate of chronic symptomatic portal hypertension among patients with Pylephlebitis. In our patient, IV heparin was initially used, and the patient was transitioned to apixaban on discharge with interval improvement noted 3 as well as 6 months later while on the therapy. And so given the lack of a larger trial, we do propose that anticoagulation therapy be individualized based on a patient-by-patient basis, carefully weighing both the risks as well as the benefits. The benefits largely involving mitigating the risk of recurrent thrombosis. And so the take-home points from this case, I would really like to emphasize the importance of having a high index of suspicion for Pylephlebitis, especially in patients admitted with intra-abdominal infections as well as polymicrobial bacteremia, because it's really early recognition of the disease process which allows for prompt intervention and targeted treatment so that portal vein recanalization can be achieved, thereby decreasing downstream sequelae of the disease. In other words, catch it before the clot thickens. Thank you.